Our next presenter and our last presenter of the morning is Dr. Andrea Holzner. Dr. Holzner is a gerontologist from the Alzheimer's Integrative Wellness Group in Portland, Oregon. Dr. Holzner received her master's in neuropsychology in 2020 from Walden University in Minnesota and her PhD in gerontology and neuroscience in 2021. As a certified clinical psychologist, neuroscientist, and published researcher, she is actively involved in helping provide those with Alzheimer's and their loved ones with the highest quality of life. Via the troika of her degrees, gerontology PhD, post-baccalaureate in neuroresearch, master's in psychology, Dr. Holzner is able to address the full diapason of psychological, social, environmental, and medical challenges facing those in the aging ecosystem. It is with extreme pleasure that I introduce you to Dr. Andrea Holzner.
Good morning. I'm just going to pull up my slide. Thank you so much to the Texas Oral Health Conference for inviting me to speak. So today I have quite a bit of information that I'm going to squeeze in, so we have time for a Q&A. So primarily my focus is going to be on rural regions. However, a lot of this information can be used for urban as well. My focus is really on geriatrics today, and our key objectives, I'm going to really focus on looking at the geriatric population, who is the geriatric patient, causes of dementia, what that looks like in terms of dentistry, defining approaches, and understanding vulnerable populations in rural areas, and practical applications to rural settings. And much of my focus is on Texas, however, because Texas is one of the highest in not only rural regions, but really having a need for dental approaches and a dental need for dentistry in rural areas. But the statistics can be extrapolated nationally. So I'm going to move this over a little bit. So right now, as you can see, Texas is the third highest state with dental shortages. It's over 200%. That's pretty much across the board nationally, not as high. However, even with geriatrics, in geriatrics specifically, we have over a 360% deficit. So the need just for geriatric providers, dentists, audiologists, et cetera, is incredibly high. We have to get people excited to get into the geriatric field in dentistry. Part of the issues in rural regions that most of us know is we have poverty, food scarcity, housing. Right now in Texas, the last number I saw was 14%, but I believe it's higher than that of a population demographic 65 and older. We also in rural regions have to think about culture and language and diversity, with 40% Hispanics, having translators and having dental information translated into Spanish, and 12% African Americans. And so really understanding culture, understanding how to present resources and information is incredibly important. Also, just really understanding the transportation and how to reach your population. So in Texas right now, we have more than 400,000 adults with Alzheimer's. Sorry, it's very early here. And across the board, of course, our Alzheimer's cases are increasing with our aging demographic. I think you've all heard the numbers of baby boomers turning 65 at rates of 10,000 a day until 2030. Our aging population is growing, and thus we really need dentistry to be prepared. I often refer to active dentistry, and that really means we need to kick it up a notch and really understand geriatrics and the needs of our older patients. And so I'm not going to go into all these, but it's really just really showing that there is a need in Texas and nationally for geriatric dentistry. Part of when I work with populations in vulnerable population task force nationally is we really look at this index, this social index. I like to call it a vulnerability social index. And in those regions, we really have to look at our population. Do we even have clean water, food scarcity? What kind of social systems are present, and how can we, I say we as dentists, I'm not a dentist, but how can dentists really interact and collaborate with social services and educate, and we'll go into more of that, but really providing a resource as a dentist and your expertise for continuing ed, for training local CNAs to enhance their dental skills. So who is this geriatric patient? I'm going to get into that in 1 second. I just want to go over just a couple terms. Of course, we all know dementia, cognitive decline. A lot of people refer to dementia as sort of this blanket, but it's really, dementia is a term of cognitive decline, and many things can, of course, cause dementia. Traumatic brain injury, Alzheimer's, aphasia, Parkinson's, vascular events like strokes, traumatic events, PTSD. Many things can cause that. And of course, one of them is Alzheimer's, and it's the most pervasive, most aggressive, and it really affects our behavioral health. And behavioral symptoms seem to emerge as the phases and stages of Alzheimer's progresses. Geriatric patient, thank you for Social Security for defining 65 and older. I like to say that I did research last year, and primary care physicians referred to anyone 60 and older as a geriatric patient. Well, I think it's fair to say that if I called someone 60 who is 65 geriatric, I might get punched because people are living longer, and they're active, and they're healthy. And right now we have less than 20% that have Alzheimer's and some form of dementia. So the bulk of our senior citizens are vivacious, they're active, they're engaged, and not geriatric. They're just older adults. And I think there is a difference to geriatric dentistry. So here's just a brief normative dentistry: older adults that are healthy, functioning, they're active, they have mental, cognitive coherency. You can just have normal dentistry and begin to have conversations with your patients on the health of their teeth and where they want to go. My dentist asks me every time I go in, do you want to keep your teeth? And I laugh every single time. And I'm like, yes, I want to keep my teeth. And she's like, okay, this is what you need to do. If you do this, you will. And so it sounds silly, but these are conversations that we need to have. With the geriatric adult, these are adults that have, of course, cognitive decline, dementia of some sort. They have comorbidities. They might be on dialysis. They might have heart disease, blood pressure, a number or diabetes. There's a level of frailty. And what I want to say about the geriatric patient is there's a level of dependency. And so that really is the defining factor, is the level of dependency. And at some point, when patients start having mild dementia, that really is the trickiest stage, I think, for adults, because most adults don't want to recognize that they're having these issues, and so they don't want to talk about it. In fact, it's very common to see them be very closed about it and defensive, because there is that level of awareness that if they announce it, it's on their record, and they could have that option to be put in a long-term care facility. And in fact, in research, that's the number one fear of older adults once they recognize cognitive decline. So geriatric dentistry really requires active dentistry, and we'll go into that. Geriatric patients, again, diabetes, respiratory diseases, cancer, cardiovascular. Often there's comorbidity along with cognitive decline, and there's a higher level of awareness in terms of obtaining medical records, working with the cardiologist, even having a pharmaceutical consult. I really think with any patient, but with a geriatric patient, there really has to be an integrative approach to care. And that means working with the caregiver, with the power of attorney, with the physician, with the cardiologist, et cetera, and understanding the full parameters of their health conditions. So some geriatric determinants, again, dementia, diabetes, vascular Parkinson's, arthritis, even pain management. We'll get into that. Pain management is incredibly challenging with geriatric patients, especially as their cognition progresses. And so these are just some determinants that really factor into dentistry. Another aspect, and literally I can spend a 3-hour workshop on this alone, is polypharmacy. So one of the aspects of many patients, but specifically geriatric, is that they are taking 5 or more prescriptions. And these prescriptions have interactions, and they have side effects. And some of the side effects are frailty, loss, a bone loss. They could affect gums, et cetera. And so it's incredibly important to have their prescriptive listing from the doctor. The challenges right now, having medical records, with so many medical records being separate and systems separate, many adults can go to multiple doctors. So it really enhances the challenges. And of course, when they begin having mild dementia, they might not even remember the types of prescriptions that they're on or the doctors that they went to, or they might not convey that to the doctor. Secondary conditions, et cetera, with polypharmacy can mimic Alzheimer's. Many patients that I find with mild dementia, because they begin misusing their prescriptions, or they might forget or take too many. And then they also have a lag on their daily, their grooming, et cetera, can develop UTIs, which mimic dementia-like symptoms. So really having this comprehensive and integrative approach is important. Again, with polypharmacy, with prescriptions, there's a functional loss and there's a dependency. Oftentimes, it increases vulnerability of falls, of tooth, bone loss, an increase in caries, contributes of gum disease, and et cetera. Geriatric patients often don't drink as much, so they get dehydrated. So there's a decrease in salivation. So these are all physiological manifestations of their comorbidities, of prescriptions, et cetera. And so, and lack of nutrition. So again, active dentistry when we're looking at the geriatric patient. So as baby boomers age, and again, 20+% of them are going to have some type of dementia. And it ranges in severity, and it's challenging to talk to your patient and really ascertain these changes. Several times when I'm talking to a patient, there's this lucidity, there's this clarity, and I can't really determine a level of dementia until I start looking at present tense, past tense, really looking at complex issues, looking at multiple concepts. And that's really where you begin to see there's a gap. Dementia affects, of course, memory, mobility, reasoning, and critical thinking. And so when working with dentists and doing assessments, I often will talk to them about having some key questions that they might ask that really ask their patient to have more of a critical thinking response and see what the response is, and begin to have that conversation. Again, dementia can have multiple causes, even alcoholism, again, drug use, misuse. And oftentimes it's not intentional, but when an older adult begins to have mild dementia, they might forget the medications that they've taken and take too many, or not take them, or and take them with alcohol. And of course, it just exacerbates the situation. So getting into more of the behavioral impacts of and how that impacts your dental practice. You'll see with mild and moderate dementia and Alzheimer's that there might be behavioral shifts of agitation, of more anxiety, very fidgety, unable to understand. And so at this point, often patients are forgetting their daily dental care. They're neglecting toothbrushing or flossing. And there's a heightened level of anxiety or fear in dental care. And of course, this can increase infections, general health, caries, etc. So there's really, it's very challenging again with at that mild. Once they get to the moderate, they typically have a caregiver. And at that point, it's important to bring the caregiver into the conversation and have the caregiver, in the appointment with them. So again, some levels of Alzheimer's, you can take this, print this out and look at this. Mild, they're independently functioning, normal activities, memory losses. They begin having gaps. And it's not just, we all forget things, but it's really a chronic stage, and there's gaps in remembering, and it issues with organization and remembering daily care, healthcare, and management. So for dentists, it's typical. You begin to have active listening and communication and normative dentistry. Where we really change is in the moderate. Again, they have a higher level of dependency, and you really begin to work with the caregiver. When you're working with nursing homes or long-term care homes, really, I would say to really engage with that home. And if they don't have an on-staff or dentists that are connected with there, maybe have find resources and work together with other dentists to provide that training and education for those CNAs and the nurses on staff. Mild to moderate really involves active dentistry. And then, of course, more severe Alzheimer's, it begins to get very challenging. And oftentimes it's just better to use sedation methods. It's just more manageable and easier on the patient. So we're going to begin to talk a little bit about communication. When with geriatric patients, especially when you notice behavioral changes and such, really it's at this point, I can't even stress how this slide is so important to have. It's really about agreeing versus arguing. Not that you would argue with patients, but it's just a level of agreement. Divert instead of reason. Once they begin to mild, moderate stage, it's very challenging to reason, and you just have to divert. I always say redirection, and have the caregiver present to help redirect, so their focus is not on something that's upsetting them. Distract versus shame, and obviously a lot of these are not going to happen in the dental office. However, many times our verbiage and our approach can seem very invasive. And so I like to really say that it's better to explain concepts in very singular sentences. And instead of saying, Mr. Smith, we're going to have you lay back, and we're going to examine you and open your mouth, and we're going to put this in. That's like 6 concepts. You lost them on the very first one. So it's incredibly important to just have in the moment singular statements. And again, that comes to reasoning, where they're not able to make that distinction, and it can be very agitating. So reinforce, mimic, model. And instead of "I told you," just repeat. And it's just a less invasive, and it can really calm those behavioral volatilities that can happen. When you're working with geriatric patients, it's really important to begin to understand the person, and not just the health issue, and really be present in the moment. And that's the challenge with geriatric patients, is that you might even have this comprehensive medical records in front of you, but in the moment, something might have triggered that patient. So you're constantly having to assess and reassess if you can even continue, if you have to take blood pressure, or if you need to reschedule, if you need to admit them to an emergency room. So with geriatric patients, there's a constant active dentistry, active listening in the moment, recognizing environmental needs in the moment. Many times with geriatric patients, I like to first have the caregiver there, and have someone present that could distract them. Sometimes it's even having a bolster or a prop, or a stuffed animal. It seems silly. My 80-year-old dad, who has mild dementia, he's 6'3" and a big guy, and I happened to get him this seal, which I get my patients, this big stuffed animal, to kind of calm his nerves. And at first he thought it was silly, but he uses it all the time. It's very comforting and soft and reassuring. And so even having something like that in the moment could calm your patient. And then learning some communication skills on how to approach geriatric patients, as well as engaging caregiver. The caregiver is an integral part of medical management, as they're the ones that are going to really enforce and ensure that their dental hygiene is being cared for, and they're looking at any pain management, etc., and can really communicate and describe any changes that are happening to your patient. And of course, really looking at any stigma, negative feedback, looking at ageism, really focusing on yourself and your staff on your views on aging. Many times lately, there's a kind of this buzzword of elder speak. I'm not sure how I feel about it. However, just because somebody has Alzheimer's doesn't mean they're automatically a 2-year-old again. They are still an adult, and they don't need to be talked to as if they're a child. Their communication is limited. And so you have to learn almost like a new language of how to communicate with someone that has Alzheimer's. But it is an adult. They are an adult, and they want to be talked to as an adult. Many times with my patients, the caregivers will come in and talk to them as if they're a child, and my patient will look at me and roll their eyes. So these are communication techniques that are really important to learn. And of course, calming your patient with laughter and humor, and really just enjoying the moment, if that's possible. So again, a few tips. Explain in very clear, singular concepts, as I mentioned. Incredibly important, because they don't have that understanding of concepts, and oftentimes there's a gap which could enhance behavioral upset. Refrain from Mr. Smith, do you understand what I'm saying? It's very frustrating because oftentimes they don't. And it's in a way, not that you're intentionally doing it, but it could be shaming, and it could increase their level of agitation. Mirror or demonstrate on an assistant any techniques that you want them to use, a type of brushing. Ask questions instead of, Mr. Smith, do you have pain? To where is the pain? Again, it comes back to, even with mild dementia, that often patients don't even want to express that they have pain and those complications. And so asking where is the pain, they're more apt to just focus on or point to where the pain is, especially with moderate to severe dementia. And again, just gently repeat steps or repeat what you're doing. Geriatric dentistry really requires a level of patience. And another element that I would really strongly suggest is, when you're scheduling, really give extra time for your geriatric patients and not be rushed, and your staff not be rushed. And it might take a little bit longer to get through the appointment. And then clarify the treatment plan with the patient and the caregiver. Oftentimes, working with dentists, we provide procedures that have pictures, and again, mimicking, etc. Discussions with caregivers, really just simple language, nothing really medical or anything. Simple questions and procedures, engage in dialogue. Again, print out information of what they need to, how they need to perform daily hygiene, dental hygiene, as well as resources. There are so many geriatric dental tools and equipment out there, brushes that have a wider handle, that are easier for patients to hold, and just more fun, engaging for their dental hygiene. So really look into those. Again, using bolsters, working with families on how best to administer any kind of fluoride or liquids, or what they need. Again, also just going back to patients with prescriptions, when patients come in after the initial assessment, and when if you need to do a surgical procedure, definitely look at their prescriptive list, at their medical conditions. And I always say, take their blood pressure, take their vitals for geriatric patients, to really understand, again, what is happening in that moment. That's really the critical point with Alzheimer's, is things can change very quickly. There could be a fall, there could be a trigger, a traumatic event. Just even going to the dentist could be triggering. And so we want to just really look at what's happening in the moment. And sometimes you'll have to reschedule or talk to the physician and come up with an alternate plan. Again, with geriatric patients, there could be really progressive tooth decay, right? Bone loss, a lot of times locked jaw, tobacco stains, if they have a lifetime of smoking, etc., or chewing tobacco, discoloration. And then, of course, one of the huge significant issues is removing dentures and cleaning, especially as adults move into more of a mild dementia. So these are all areas that you'll quickly ascertain. One of the connections that you probably all have read about are diabetes and oral health, right? And so this is incredibly important. When I work with patients, one of the first changes that I make is to their nutrition, really looking at even these protein drinks, especially they're especially high with older adults. I won't name them, but they have a very high level of sodium, very high level of sugar, and it just really increases their chances of diabetes. And of course, diabetes and gum disease, et cetera, have been linked, as well as a link to Alzheimer's. And many times infection and pain could really exacerbate cognitive functioning, and many times mimic dementia. And once they have adjusted their diet, they have their diabetes under control and their infection under control, they've noticed an improvement in their cognition. Again, geriatric patients do not always communicate their needs. There's just this higher level of fear of communicating at times. And so oftentimes you'll just have to, in your assessment, as you're feeling around, just notice any changes in expression, in wincing, etc. And then, of course, working with caregivers. If there's any changes, loss of weight, lack of nutrition, etc., many times you'll see this in the medical records. Of course, if they're in a nursing home or an adult community, you can read the nurse's notes and really learn about that. Sugar, carbohydrates, all of these, of course, affect patients. And then speaking to caregivers about changes in eating routine. And oftentimes, the caregivers might not even be forthcoming, but of course, when you make the assessment, you can see with tartar and plaque buildup, et cetera, changes, especially if this is a long-term patient. So your role as a provider with geriatric patients, what treatment to use, how, if you have to alter treatments, when to use it, how to apply it differently, and who authorizes this treatment. Once you realize that your patient has dementia of some sort, and even if you get the medical record and it notes dementia diagnosis, but there's no caregiver or there's no official power of attorney yet because it's still in that tricky stage, it's very tricky on who authorizes, because the patient is sort of waning in and out of clarity in reality. I really strongly recommend, for liability on your practice and also for the patient, to have more of an integrative approach with the medical provider and come up with a comprehensive treatment. Again, this is a level of trustworthiness. Of course, it's self-explanatory. With geriatric patients and with families, really having a level of transparency of what you're doing, of what you want to do, working again with the primary care, giving notes and evaluations, sharing with family, talking with the caregivers, power of attorney, and having a real comprehensive approach. Again, it just lowers the level of behavioral agitation. It also helps with caregivers and family members as they're understanding what's happening. So rural access, again, the patient in rural communities, we're really looking at family resources. We're looking at social, environmental, the proximity to patients. How can we really focus on looking at echelons of government, local government, at resources, working with caregivers? How can we enhance education for local students? How can we get interns out into the field to do home visits or for local community centers? There's really a lot of resources right now that are being deployed. It's just there's such a huge population that we can't reach everyone. However, really looking at ways to work with social workers, with Alzheimer's patients and geriatric patients and medical support. I really say the biggest part of it, if you can, through telehealth or face-to-face, is really empowering the adult, really empowering the caregiver, and giving them as much information as you can to minimize pain, to minimize infection, and really, again, active dentistry, looking at what are they eating, what's happening in the home that is increasing their caries or causing this chronic gum infection. Why are their dentures not being cleaned? Maybe even looking at local resources that have CNAs or nurses that do outreach and working with training in that sense. Of course, with COVID, things have changed tremendously. Again, I just really urge outreach and training as much as possible. Of course, insurance is a huge factor, and really, I mean, looking at the presentation earlier in Arlington, I was just so overjoyed to see the work that they're doing in terms of outreach and just free dental or sliding scale, working with social workers and seeing what other options are available, online access. Oftentimes, when we're empowering the caregiver and the adult, like through telehealth or whatnot, we can begin to minimize, again, foreign language skills and services and outreach. I'll try to wrap it up as best I can. Really looking at one of the areas in rural communities is that adults are isolated, right? It's not just insurances, that they're isolated and they need to have that outreach. And so social workers in those areas and resources. One community, Villages Northwest, they are national, and it's run by volunteers that are background checked. And they do a lot of outreach, and they'll provide transportation and bring patients in, etc. As well as focusing on your local human services and department. So a couple other areas that I say for dentists is you really have an opportunity to be a leader in your community. And that sounds like a lot of rhetoric, but I really mean that from my heart, is you have to do outreach and education. If you can afford television ads or letters, maybe getting brochures out, maybe doing webinars, free webinars, community services at community centers, again, at nursing homes, having a chance to provide continuing education that can just kick up this geriatric training. Again, working and understanding vulnerable populations. This presentation is so condensed, but I literally spend an hour just working on communicating with geriatric patients and what that looks like, and practical applications to dentistry. So these are continuing education courses that will really help you to understand your patients. Again, an integrative approach, working with medical, government, even changing your reporting, and providing a trusting environment, really looking at your accessibility. When your patients walk in your front desk, how is your front desk responding to this geriatric patient? Are they speaking so fast that they can't even understand? Or are they speaking to them in this childlike tone? Are they providing safety and making them feel welcome and calm? Do you have wheelchair accessibility, et cetera? So again, these are just really areas to learn and focus on. Looking at oral health literacy, getting those resources out there, empowering your community, and maybe even providing a workshop, an educational workshop in your local. I'll let you read those at your own leisure. Again, nursing home environments, the education, providing supplies or tools if that's possible, working with local authorities, echelons of government, et cetera. And I think I'm running pretty close. So my apologies. Understanding. So with the geriatric patient, we really want to be in the moment, understand their needs, working integratively and comprehensively with their medical cardiologist. If they're on dialysis, working with that clinic, looking at their prescriptive list, their caregiver, and being in the moment really involves active looking at their expressions and what's going on. In closing, I would just say that this definitely involves continuing your education in geriatrics and communication, and just begin having a strong outreach. And again, I know that I know there's a limitation on what's available, and it can be very frustrating to not be able to reach everyone in your community. But as we begin to educate and train and empower those in the local regions, I think we'll begin to see a shift in that. And thank you. And of course, if you are looking for unique one-on-one assessments or training, feel free to contact me.
Well, thank you, Dr. Holzner. That was a very informative presentation. We appreciate that.